Afternoon, everyone, and welcome to the Support Hospital Opioid Use Disorder Treatment Shout Texas Echo. Please note that we are recording these sessions for later distribution. Please note that anything listed in the chat does not appear in the recording. My name is Shreya Prasanna, and I will be your facilitator today. A few quick announcements before we begin. To help us with attendance, please enter your name, affiliation, and email into the chat function. To access the chat feature, click on the speech bubble icon on the navigation bar at the bottom of your window. To all the Be-Well Texas providers, please make sure that you identify yourselves during the session, or if you're joining via phone, please email your phone number and name to bewelltx@utisca.edu. Some housekeeping: please stay muted unless you're speaking. If you join by computer, your mute button is on the bottom left of your Zoom controls. If you're on the phone, please press *6. We also encourage you to unmute and speak, especially during the discussion portion of our session. We want to hear from as many of you as possible, so please keep your comments brief to allow time for others to speak up. Or if you'd prefer, you can use the chat feature to share comments and questions. Please note that no protected health information is allowed in either the chat or our discussions. If you'd like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. You may need to click on More at the bottom right of your Zoom screen to find this menu. If you're having trouble accessing captions, please chat Echo IT. Towards the end of the session, the Shout Texas team will send out a link to an evaluation survey. All participants filling out the survey will be entered into a raffle for a $30 Walmart gift card. This will help us get valuable feedback from you about how we can improve these sessions. Our didactic today is on how to manage opioid use disorders in birthing patients and will be presented by Dr. Zach Sartor. Following that, we will discuss a case presented by Dr. Daniel Levin. We will start with introductions, didactics, Be-Well program announcements, followed by the case presentation and open discussion. Thank you all again for joining today's Echo. In the spirit of all teach and all learn, we encourage you all to share your experiences, questions, and insight in today's conversation. And with that, we will do some introductions. Dr. Weems.
Hey all, Dr. Weems, internist addiction medicine doc here at Community Care FQHC and with the Shout Start team at Dell Internal Medicine. Really looking forward to the didactic in case today.
Thank you so much. Dr. Ramesh.
Hey everyone, I'm Jan Ramesh. I'm a hospitalist at Dell Medical Center.
Thank you. Dr. Chris Moriatis.
Chris Moriarty's hospitalist, and I'm at Del Med and the Shout Start team.
Thank you so much. Dr. Blair Walker.
Hey, Blair Walker. I'm with psychiatry at Del Med and Del Seed Medical Center.
Thank you so much. Dr. Lindsay.
Hi, everyone. Adrienne Lindsay, Director for the Center for Substance Use Training and Telementoring at Be-Well, Texas.
Thank you so much. Alana.
Hi, good afternoon, everyone. I'm Alana Bolton at the University of Texas Dell Medical School with the Start and Shout team. Thanks so much for being here today.
Thank you so much. Dr. Sartor.
Yeah, I'm Zach Sartor. I'm in Waco, Texas. I'm a family medicine faculty physician and the director for our addiction services at Waco Family Medicine.
Thank you. Welcome. And Dr. Levin.
Good afternoon, everyone. I'm Dan Lavin. I'm an addiction psychiatrist based out of Temple with Baylor Scott and White Health.
Thank you so much. And with that, we will move on to our didactics. Dr. Sartor, whenever you're ready, you can take it away.
All right.
Thank you.
Let's see here. Good deal. Well, I'm super happy to be with y'all. This is just really cool that we get to come together and talk about this, especially since this is something that just really impacts people's lives really profoundly. If we can offer good evidence-based treatment, and it's something that I enjoy talking about. So thanks for having me. So we'll talk about OUD in birthing patients. And first of all, I don't have any relevant financial disclosures, no commercial or otherwise. So I'll start by talking about substance use screening. And I think that any sort of time we talk about substance use in pregnancy, we kind of have to start with screening standards during the perinatal period. Then moving on, talking about perinatal impact of OUD specifically, and then talking about generally medication for opioid use disorder for OUD, but then focusing in on office-based treatment pearls related to buprenorphine. All right, so substance use screening in pregnancy is something that's recommended universally. And so I say screening is recommended universally by a number of different folks. The WHO, the CDC, ACOG is the American College of Obstetricians and Gynecologists. This is important that when we talk about screening, when we say screening, the general lay public, or even a lot of people in the medical professions hear screening and they think urine toxicology testing. But really what we're talking about is screening in the true spirit of screening, which is validated questionnaires or clinical interview. So importantly, the standards are not to screen only those patients who have a known history of substance use during pregnancy, and then generally to use some sort of systematic structure for that screening process. And so the screening, brief intervention, or referral to treatment paradigm is something that we use in our clinic system. And the screening piece of this, although it can be varied, ranges from any sort of validated screening questionnaires like the NIDA single item screening, or those specifically validated in pregnancy, which would be the model that the American College of Obstetricians and Gynecologists uses, is what's called the 4 Ps. So past, present, partner, or, oh gosh, the 4th P, whatever the 4th P is. Anybody can help me out. I'm blanking on the 4th P. Past, present, partner, or, oh, parent, I think it's parents, like family history of substance use, I think. Okay, man, all right, dodged a bullet there. And so really, to me, this is the most important part of this is whatever sort of structure that you have in place in clinic, is being systematic is going to be more important than having one specific type of screening versus another. This is a reference if folks are interested in looking at this later, but it reviews in sort of a narrative format the role of expert in the perinatal period and gives some recommendations for best practices. The group of experts got together, came up with their sort of ideal best practices for what this looks like specifically when applied to the perinatal population. And here's just a summary of those key screening recommendations. So screening for substance use done on all pregnant women, again, speaking to that universality of this. Screening done either using a validated instrument or by asking standard questions, that's structured clinical interview. Non-judgmental, open-ended question asking, and then really importantly, urine toxicology testing should not be used in place of substance use screening, which I'm not sure how the practice environments that you're in are, but our culture unfortunately very much leans toward really relying heavily on urine toxicology testing in lieu of standardized screening, or use of the urine toxicology testing inappropriately instead of asking some of these key clinical questions. That's something that we've really tried to fight back against with the use of standardized protocols and order sets, and then just targeted clinician education. So just a review of our expert model in terms of the inputs of universal screening and the outputs of risk stratification and potential treatment and follow-up recommendations. So NIDA has a clinical trials network that actually has an interactive sort of tool that you can use to craft a screening and implementation plan for your clinic system. So I thought this was interesting that for a lot of folks who are working towards developing sort of these standardized policies, this is something that might be really helpful for folks as they try to implement sort of that standardized approach for pregnant patients. So just wanted to share that with you. All right, Man, this is not anything that is any surprise, but anytime I give a talk, whether it's residents or other clinicians or the public, I always like to lead or have this included just to help really frame the issue, even though we've seen it over and over and over again. But every time I see it, I'm reminded that this is a very, very uphill battle that we're facing right now. But the good thing is that there's a lot of opportunity for treatment and some pretty profound impact that we can have in patients' lives. So always I like to do this to sort of frame that as we continue to talk through this. So whenever we talk about specifically in patients who are pregnant, we do see some of those same trends on the national level are consistent in the pregnant population. So opioid use disorder during pregnancy doubled from 1998 to 2011. And so the overall national epidemiologic trends, patients who are pregnant have not been immune from those. We do see there are high rates of opioid prescribing in patients enrolled in Medicaid who are pregnant or who are of reproductive age or reproductive potential, which is considered somewhat of a contributor to this overall trend in pregnancy-related opioid use disorder. And then the flip side of this, right, when a patient's pregnant, we've got two patients. We've got the mom and the baby. And so on the other side, we see neonatal abstinence syndrome, or now what we call neonatal opioid withdrawal syndrome. These rates have increased in that same time period. And we've started to see a similar sort of divergent pattern in that epidemiologic data, where rural areas are disproportionately affected with neonatal opioid withdrawal syndrome. The risks for perinatal opioid use disorder for mom, really, I mean, these aren't anything that's different for anybody else with OUD. So overdose-related death, infectious disease transmission, skin soft tissue infections, stigmatization, and then importantly for mom, the issue of legality, in addition to the normal legality concerns with opioid use. Looking at child protective services and having legal involvement with having a child. My doggo may interject every now. My dog may interject now and then because she just gets really passionate. So sorry about that. And then to baby, whenever we look at baby and the risk to baby, it's going to be low birth weight and preterm delivery, and then neonatal opioid withdrawal syndrome. Those are the sort of the major physiologic risks, and then the psychological risk of removal from mom, right? I mean, we can't understate that is a huge potential risk to baby whenever we have opioid use disorder during pregnancy. Oh, let's go back. There we go. So neonatal opioid withdrawal syndrome, like I said, the trend has been divergent. It's become more and more common in rural areas, or that rate of rise has been higher in rural areas. Both in urban and rural areas, rates are going up, but that rate of rise is definitely higher in rural areas. And I think this mirrors some of the trends that we've seen with the opioid epidemic overall, where rates are going up across the board, but in certain areas, especially rural areas, those rates of rise are higher. This is, when we think about neonatal medicine in particular, this is also has some potential consequences, because rural areas generally are less likely to have NICUs, less likely to have higher levels of care nursery, like level 2 nurseries. And so potentially don't have the infrastructure necessary to care for some babies with neonatal opioid withdrawal syndrome, which could necessitate transfer to another facility, which adds another layer of just that maternal infant dyad separation risk. All right, when we talk about treatment during pregnancy, very important that medically supervised withdrawal is not recommended. I mean, generally across the board, this isn't an optimal treatment strategy for anybody, but during pregnancy, it can be actually potentially dangerous and is not recommended. So the reasons for this recommendation are twofold. One is it's ineffective. So medically supervised withdrawal or you kind of quote unquote detox to abstinence is ineffective for folks. And then two, the actual physiologic strain and stress that can accompany supervised withdrawal or just withdrawal in general can be potentially dangerous for baby, can cause in utero distress. And so even when we're doing inductions for medication for opioid use disorder, which I'll talk about here in a few slides, we're going to have some pretty specific recommendations in terms of how we can monitor baby during that time. There is this theoretical risk of that stress precipitating preterm labor and preterm delivery. I don't know that that's ever played out on a sort of large evidentiary basis, but it is a risk that we worry about and that we talk through. And I think more than anything really reinforces this idea that medically supervised withdrawal is not the right strategy for these folks. So whenever we talk about what is that standard, it is going to be medication for opioid use disorder. So the WHO, the American College of Obstetricians and Gynecologists, and NIDA all have fairly unequivocal positions on the appropriateness and the preference for MOUD during pregnancy. Both have been shown to be safe, both have been shown to be effective, and while the risks of neonatal opioid withdrawal while on these medications isn't low or isn't small, the absolute risk compared to folks who aren't on medication for opioid use disorder and the subsequent risk to baby, including preterm birth and low birth weight, still that calculus still favors medication for opioid use disorder, even when you account for those cases of neonatal opioid withdrawal syndrome that can happen with MOUD. So whenever we compare the two, the way I usually sort of start is by saying that methadone has been around for a long time and really has been the standard of care during pregnancy for a long time because it has a long track record of safety. And I think whenever we're talking through perinatal medicine, we always talk about efficacy and safety hand in hand. And in fact, if the burden of proof for safety to the fetus isn't high enough, then despite strong evidence for efficacy, medication or some sort of therapeutic modality may not be standard of care for the perinatal population. But buprenorphine has been shown to be safe, been shown to be effective, and there's more and more evidence in comparison head to head with methadone that I think the pendulum is really swinging towards buprenorphine. And then when we think about this from just an access and in a public health standpoint, buprenorphine is going to be more accessible to more people, especially in rural areas where that neonatal opioid withdrawal syndrome risk is trending higher and faster, faster compared to those in those urban areas. But a head-to-head comparison, we see, and we talked about the gold standard, historical accessibility, the sedation risk here. Mortality benefit, of course, is the same. Both have those HIV and hepatitis risk transmission reductions. And the sort of large data set that we have up until recently, we tell us that about 50% of babies on either medication are going to have some level of neonatal opioid withdrawal syndrome. Now, this isn't to say that 50% of babies are going to need to stay in the hospital or in the NICU with neonatal opioid withdrawal syndrome, but 50% are going to have some level of opioid withdrawal, whether that's mild, moderate, or sometimes those severe cases that do warrant neonatal intensive care and more intensive treatment. But we'll talk about some actually super recent data that shows that may not tell the full story here. And I'm happy to share that with y'all in just a second. And then again, looking long-term developmental risk or adverse events in childhood development, there's really no evidence that shows that either of these medications has any untoward effects. All right, so like I mentioned, the sort of the neonatal opioid withdrawal symptom piece has been something that a lot of people have been studying over the last 10 years in particular. And we see in the American Journal of Epidemiology here, this was 8 years ago now, showed that buprenorphine decreased the rates of what they called NAS, which now we call it neonatal opioid withdrawal syndrome, decreased rates of hospitalization for that, and for those folks who were needing to be in the hospital for neonatal opioid withdrawal, decreased doses of morphine. So I think this was really encouraging in us really pushing buprenorphine more and more compared to that historical gold standard of methadone, especially for folks who had really difficulty, accessing opioid treatment programs. And then this came out about, I think a week ago today. It was online before that in the New England Journal of Medicine, which was just phenomenal. So comparing buprenorphine and methadone for opioid use disorder in pregnancy. And what they found, they took this large cohort of over 2.5 million pregnancies and divided those who were receiving a medication for opioid use disorder by what they were receiving, buprenorphine or methadone, and then compared outcomes between the two. And so neonatal opioid withdrawal syndrome, or they say neonatal abstinence syndrome, occurred in 52% of infants exposed to buprenorphine within 30 days after delivery, as compared with 69.2% exposed to methadone. And so you see that risk reduction, the adjusted relative risk of 0.73 for folks on buprenorphine compared to methadone, which is pretty divergent from what we've seen historically, which I mentioned that table that was from the NIDA policy briefing, about 50% for both. The thing that I think is really sort of jarring about this is that the preterm birth rate were different between the two. Gestational age were different between the two, and the overall risk for low birth weight were different between the two as well. All of these favoring buprenorphine. Same for cesarean sections. And so it's interesting, and I'm still taking my time to kind of go through all of the data in the paper to kind of see. The thing that I always think about whenever I see something like this is that if there's some sort of severity bias for the patients that self-selected towards methadone, or what other confounding issues may have been present in sort of this data set. But to me, I think this is really supports the fact that I think from a what's the best solution for the most number of people who are pregnant, who have opioid use disorder, it is going to be, I think, buprenorphine. And this really adds to that. So some clinical pearls focusing specifically on buprenorphine in pregnancy. So Subutex or Suboxone, this is sort of the sort of catch-22, like I mentioned, with medications in the perinatal period, where we, Subutex and Suboxone equally effective, right? But the Suboxone has never been sort of independently verified as safe because of the naloxone component has never been evaluated during pregnancy to say that this is definitely safe for someone who's pregnant, which is somewhat of a ridiculous argument, right? Because naloxone, when taken appropriately, isn't bioavailable sublingually, and so it shouldn't be a risk to a fetus. But because of this sort of unfortunate sort of pattern of thinking that we have to fall into whenever we consider things like safety data in pregnancy, we are going to recommend Subutex more times than not. Now, so I just personally, I use still a lot of Suboxone with patients who are pregnant, but we have a discussion about that sort of the conundrum of not being able to study something that shouldn't even be a risk in the first place. And most of the time patients they get it, they understand. And so we'll still default the Suboxone. But if you when we've talked with folks up at MGH in Boston, they'll say that the sort of the company line still is Subutex probably first, Suboxone is a reasonable alternative. Doses are likely to increase in the second and third trimester. This is really, really important here. I have had a couple of patients who will come in and tell me, I'm having more cravings, and it's, around 26 to 28 weeks. And the physiologic changes that accompany pregnancy lead to quicker clearance of the medication. And so you may need higher doses in that second and third trimester to achieve a similar effect to what you had during that first trimester or before that they were pregnant. It is okay to continue this in labor. Very, very okay. And in fact, this is something that we were having this talk 3 or 4 years ago. There would be kind of 50-50. Maybe you continue, maybe it don't. I think that now we're really at a place where continuing buprenorphine or methadone for that matter, while someone's in the hospital, should probably be the standard compared to stopping it. One, it's just, it can be an effective analgesic, and you can do some things to potentially maximize the analgesic effects of it. I'll talk about that in just a second. But two, you stop it and then have to restart it. It's just really, really difficult for some folks. And so this is something we encourage folks to continue during labor. I get calls every once in a while from labor and delivery, kind of talking through this with folks who are having patients on Suboxone who are in labor or going for a C-section. The strategies you can kind of use to help with the analgesic potential of it is using more frequent dosing. So if someone's on 8 twice a day, using 4 times a day to sort of maximize that analgesic window of about 6 hours or so. And then using full agonist opioids on top of the partial agonist. Totally safe, totally fine. And recognizing that you may need to use higher than typical doses for those full agonist opioids to achieve that effect because of the action of the Suboxone at the mu opioid receptor. The other thing is, of course, going from 8 to 4 milligrams of Subutex or Suboxone will sort of open up another something like 25 to 50% of receptors. It can be a lot. And so you can get more windows to sort of throw on that full agonist opioid. And then lastly, it is okay to breastfeed. It is encouraged to breastfeed. If a mama wants to breastfeed, we want them to breastfeed. In fact, we think that maybe this will actually decrease the risk of neonatal opioid withdrawal syndrome, because while very, 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 very little of these medications pass through the breast milk, what does can actually help with those potential withdrawal syndrome in the baby. And just to really reinforce that, ACOG has a specific committee opinion that is broader than just for opioid use disorder. So any current or past history of substance use disorder should not summarily exclude someone from nursing their infant. Okay, I just wanted to share one more resource with you. The place where I work, we have a group of us who, about 6 or 7 years ago, realized that there's a lot, obviously, to manage in that primary care setting in terms of behavioral health, and developed a point of care resource for folks to use for psychological and pharmacologic treatment of behavioral health disorders. And the reason I bring this up is because one of the tools that we have on this website is specific for perinatal opioid use disorder. And so it kind of lays out everything that we talked about, kind of goes into a couple things that we didn't talk about, like naltrexone use and the sort of specific antepartum screening and monitoring recommendations outside of just the substance use treatment. And this is free to access. You click, can follow the link wacoguide.com and access that. We have a specific substance use disorder section that has some other tools, and has some other tools related to antepartum substance use disorder beyond opioid use disorder. So happy to share that with you. And I think that's it. I think I'm just a little over time, but got through everything.
Thank you so much, Dr. Sartor. This was a great presentation and a very, very pertinent topic. Just want to open up the floor for any questions from our learning community.
I had a question, Dr. Sartor, and I appreciate you talking with us. Very, very interesting. I'm curious, because you're just up the road from us. What is your general reception like by the community providers there in Waco?
So general reception, meaning
in terms of openness, I guess, and acceptance maybe for maintenance therapy and pregnancy and that sort of thing.
Yeah. So yeah, and sort of to really put some context on this, I mean, we have one opioid treatment program in town, and then we have maybe 2 places where folks can access office-based treatment with buprenorphine. And so this is still very much we're still very much on the far end of the sort of learning curve in terms of MOUD being just really, really commonplace. And I've had to do, I think, a lot of sort of targeted education for folks. But I will say the sort of the good news is that in talking with, especially like at the hospital, our labor and delivery staff and other providers, it's come more from a place of not understanding than a place, I think, truly of sort of moral judgment or sort of just hesitance to provide medical treatment and thinking about sort of medication for opioid use disorder as sort of a true medical treatment. And so that's been really encouraging. And I think that in that regard, people have been pretty accepting. And we've had I think we've got some really good cases of some really, really big successes as a result of that.
I see a hand raised. If you could please unmute yourself. Yes, Lindsay, but you're not Lindsay.
Yes, I'm so sorry. Yeah, my boss let me log on under her account. But I had a question because I know you didn't go into naltrexone very deeply, and I wanted to know if low dose naltrexone or ultra low dose naltrexone, like continuing that use to like the upregulating of like endogenous opioids, if that's like a thing that's entering the field of like pain management treatment long term, if your facility has like begun to like actually implement that kind of stuff, because it's kind of newish stuff. So I wanted to like kind of ask about that.
Yeah, I actually I don't know much about that. That's interesting to hear. I will say, I mean, I can talk about it for 20 or 30 seconds. And naltrexone in pregnancy is going to have the same sort of issue that Suboxone does in terms of the naloxone component, not having any direct sort of safety data in pregnancy. So no sort of data to say that 100% this is safe for the fetus. And so unfortunately, it sort of falls into that same category of not something that we can just recommend without kind of reservations or without sort of the normal sort of informed consent discussion. Now, we'll say that, and we've gotten some support from other folks we've talked to, that if someone is on naltrexone and it's the only thing that's ever been helpful for them, and they're considering pregnancy or are pregnant now, I mean, we're going to think really, really long and hard before stopping that. And so I don't think that there's anything here that's absolutely black and white. It's something that, as long as someone understands sort of the risks or the unknown risks, and the benefits are going to potentially be, the risks of stopping that are potentially going to be far worse than the unknown risks of continuing it, then we'll have a discussion about continuing. So far, I haven't come across that. We've talked about it. Haven't come across that for opioid use disorder. Now, we've had that conversation many times for alcohol use disorder and methamphetamine use disorder, because that's been sort of more, especially with the bupropion, naltrexone combination for methamphetamine use treatment. It's a conversation we've had a lot more. And there's been some folks who are pregnant that we've used that combination on because of the, after having that discussion, so.
Thank you so much. That was a great discussion. And in the interest of time, we will move on. Angela, if you could please share the announcements. Be Well Texas is a welcoming environment with caring professionals who are ready to help people start or continue their journey towards recovery. Be Well Texas is committed to expanding equitable access to compassionate, evidence-based treatment and care for SUD throughout Texas. Next slide. The Be Well Texas Clinic offers high-quality treatment for addiction recovery at low, no pay or self-pay insurance, so all patients are accepted regardless of their payment ability. Next slide. If you need technical assistance beyond what's offered here at the ECHO session, please complete an online request form and we will be happy to assist you. You can find this form on our website at cstat.utisca.edu. Next slide. Please join us next month, Shout Echo, on Thursday, January 19th. We will be discussing buprenorphine microdosing and fentanyl. Thank you. And with that, we will move on to our case. Dr. Levin, please take it away once Echo IT shares the case. Thank you.
All right. So I need to stick to 10 minutes or less. I set myself a timer here. I'm Dan Lavin, as you guys know. So I'd encourage everybody to, at any point, unmute and shout out your questions. I want this to be interactive so you don't fall asleep. I know everybody's probably eating lunch. So that's a very high risk. This is a patient I had recently. And let me just sort of preface this by saying, I often feel like having the ability to treat opioid use disorder with buprenorphine is kind of like having an ace up your sleeve, and you want to use it all the time, even when sometimes maybe you could do other stuff. So this, I think, is one of those cases. So can you scroll down just a little bit? Perfect. All right. So be thinking about, what you do in these situations, or this situation rather. What are your concerns? Sort of what are you going to prioritize, basically? So, all right, scroll down again, please. Okay, so I'll read the basics here. I had a young woman. This is my very first visit with her. 2 months pregnant, and history of pretty significant substance use starting about 3 or 4 years ago. And it kind of ranged from alcohol to intravenous methamphetamine, and then more recently opioids, and specifically the counterfeit pain pills that are everywhere now with fentanyl. So that was kind of the history. The reason they were coming to see me was more so out of concern by the family member. The mother said, hey, my daughter's acting strangely. And, for example, she would have the difficulty relaying basic historical information, answering simple yes or no questions, just sort of kind of acting oddly. So delving into it a little bit more, it seems like most of this stuff started within the last year or so, usually sort of stemming from some sort of interpersonal conflict, basically. Okay, so that's that. Now, I should add to this, I don't think I put this in. So we're limited to 60 minutes in the appointments, and they showed up a little bit after 30 minutes. And so it's a very crammed amount of time, and right away, the patient's asking for things, mom's asking me what's going on, and there's just a lot of pressure there, right? All right, no medical history other than being pregnant, not taking any medicines, no real significant medical or medication use in the past. So, okay, so what's the history? So patient was doing very well in school, straight A student, was dual credit courses, essentially all the way up until 12th grade, and apparently dropped out with a couple of credits to go. Hasn't really been doing much since, had been sort of hopping between the boyfriend's house and mom's house, getting financial help from both of those. And that's about it. No kids right now, again, not working, no transportation. Yeah, all right, so that's that. Psych history, a little bit of depression in middle school, nothing out of the ordinary really. And starting about, let's get the timeline here, I would say maybe a year and a half ago, the patient went across country with her boyfriend, got into intravenous methamphetamine and some opioid substances. And essentially the parents go up, they're concerned, they pick her up, they're driving all the way back, and along the way they get into lots of arguments. The patient says she's suicidal. She ends up going to the hospital afterwards. And during this time, they entertain things such as schizophrenia. Parents were clearly concerned. They ended up taking her to outside provider, essentially did some sort of brain imaging and found, I guess, a number of ditzels that they were concerned about, and said, you know, were significant. And let's see, what else? No history of suicide attempts. Again, that suicidal or the admission following the ideation followed an argument with the biological father. So, all right. And that's really about it as far as the history I got. So any questions so far, feel free to shout them out. That's probably quicker. And if I don't hear anything in a couple seconds, I'll keep going. All right, I'm assuming no questions then. If you do have them, just pop them there in the chat box here. Okay, so now during the exam, the patient seemed more or less unremarkable. You know, she's doing kind of some weird hand movements and sort of not giving clear answers to questions, but the mom would give the history, the patient would interject to correct kind of benign small details. Oh, this actually happened on a Friday, not a Thursday. I was wearing a green shirt, not a blue, that kind of stuff. So really had a good grasp, I think, of what had happened. And I wasn't really appreciating any significant dysfunction. Very expressive on her face. It was dressed appropriately, no poor hygiene, anything like that. So I wasn't really seeing anything that looked suggestive of like schizophrenia or something like that. Not a whole lot there. Okay, can you scroll down again, please? Okay, so we talked about this a little bit, such a little bit of cocaine in the past, now using just regular flower type marijuana weekly. The methamphetamine had stopped when she learned she was pregnant, a little bit of ecstasy in the past, and now intermittent use of fentanyl-based counterfeit pharmaceuticals. Not on a regular basis, though. This was kind of the feeling I got was, you know, when it was time to sort of take a load off and relax, maybe just have a little fun basically here and there, but nothing consistent. Okay, did receive just a little bit of substance use counseling during one of the hospitalizations. Of course, yeah, all right, so got that. Not a whole bunch else. Scroll down, please. All right, so you can see the rest of the history there. Nothing else really significant. So, all right, I'm going to pause. And so at this point, let's assume you have 4 minutes left in the assessment, and they're really pressuring you for a diagnosis. They drove all the way here from, you know, across Texas, and what do we do, and so on and so forth. So I very much felt on the spot. I should say that there was a significant deal of conflict between the patient and her mother for the majority of the time. So it was a very sensitive interview, and I felt like there was lots of potential to really blow things up if I did the wrong thing. So what would you do?
John here from the Hub team. This is a great lecture and such a great case. And I think one of the great things about the case is it brings you into a spot we often are when we're treating pregnant and parenting folks, where time is limited, it's hard to prioritize, and the pressure is on. So I am going to totally step out and say, and actually, if it's okay, ask Dr. Sartor to weigh in, but I also just like, what a great talk, what a great case to bring up some of these clinical issues. And Dr. Sartor, if you're comfortable, I'd love to get your sort of assessment of the situation and first questions for Dr. Lavin.
Yeah, can you sorry, can we pull up the case sheet again? Is that okay? Awesome.
This was in the clinic, by the way. Somebody had that question.
And can you scroll up a little bit? Just a little bit more to the stem part here. Yeah. I guess so. Oh, just a little bit more. Oh, down a little bit more. Oh, up a little bit more. Sorry. I'm looking for family history. I can't remember that off the top of my head.
Family history is not in there, but there wasn't, I believe the biological father there was clearly a disruption there, and they weren't going to give me the history, but there's no known substance use or psychiatric history that I know of.
Right. Okay. And that was part of my question, because can you scroll down some? Sorry, that's probably really annoying. Scroll up, scroll down, scroll up. But yeah, the whole down a little bit more. A little bit more, yeah. So the whole schizophrenia at that young of an age without some sort of really strong family history, man, that seems really, really abnormal. And so I guess my first thought is sort of like to dig in a little bit more to that, and then the family history piece, which you answered. I don't know. I'm trying to think through other things. Anybody else have any other thoughts?
It's Blair Walker with psychiatry here. I think the answer is there's never a right way. And I mean, they showed up 30 minutes late. You're doing the best you can. You have a mom and a 20-year-old adult woman who is not speaking for herself much, who has been dragged in by her mother, who is pregnant. I mean, I know there's a lot of like this. I think that I would try to ally with the patient and ask her what she wants. And might even in the room say, is it like, do you feel like you want to talk separately? Like, what do you want? There's a bit, I mean, I think mom's already in the room, so that probably would blow up in your face too. But I think that's what I would ask. What do you want? I hear this story and I'm worried about substance use. You're pregnant. There are options. If you're interested, we could help you. I would, you can dig into the psychiatric history too, but I think that's where I would start. I think I would also insist if you needed to, like if she's engaged, she wants help, they might have to come back. You kind of like figure out what's your priority that day and what's her priority that day, and then have them come back and make sure they come back. Like help them understand, time. They have to come back and they have to give you enough time to manage it.
Yeah,
it's not easy though.
Yeah, someone mentioned in the comments about like separating, like having mom leave the room, and I feel like that sometimes is a helpful strategy, but it also can lead to triangulation a little bit between the patient and the mom, and so sometimes that can be really hard. But I think sometimes calling it out for, sort of putting a name on what's going on and saying, this is sort of what we're dealing with. What's the main thing that we can help with today. I really like that idea. And try to align with that patient. I think it's a really good thought, Dr. Walker.
And also, I mean, asking the mom, what particularly are you looking for? What are you the most worried about? And I think mom's already in the room. There you are. Then it becomes like it's like a family session. And it is, mom's clearly very closely involved. So I agree. I think if I were in the room, like, I don't think I would kick her out unless the patient was like seeming like she really needed it to happen or nothing was going to move forward. I don't know. It's not easy, but I think figuring out what the priorities are today, because we don't have much time and we need you to come back.
Yeah,
and I like there are really good stuff in the chat about, like Narcan follow-up records.
Can I say that I think from a recovery specialist standpoint, right? When situations like this come in, and you can almost immediately see, like, when, the dynamics between the mother and the daughter, like, why I would definitely try to, like, get the mother out of the room and just talk to the daughter, because it seems like she's kind of, not really comfortable talking openly probably around her mother, which can very often be the case, so maybe just reminding her that, mother doesn't have to be in the room, that, we have, unless she's allowing us to talk to the mother, we don't talk to the mother, but either way, that we're on her, we're on her side, we're with her. The mother's not not the patient, right? She is. And that, really just helping her feel empowered, maybe to speak up and stand up for herself can be helpful, I think. I think that she probably is just hearing her mother's voice in her head all the time, right? So having somebody kind of side, especially your doctor, it can be amazing to have them kind of support you in making the choices that you want to make. And then it can help her to open up to you and really kind of get into why she's using it. Because I mean, it sounds like if it's not all the time, there's something going on stress related that maybe she just needs some coping skills, right? Maybe she needs to be having somebody that she sees regularly, like a peer specialist, who can help her get through those times when she's really struggling, with her mental health, and so she doesn't turn to substances. And mental health and substance use peer specialists can meet with people as long as they need to, as often as they need to, right? So they can be that kind of support, that extra support.
Perfect. I appreciate everybody weighing in. So excellent suggestions. All those things were going through my head. I was mainly thinking, I felt like I was, that's my timer. I'm out of minutes, but I'll speak fast. So I felt like I was in a minefield, and everywhere I stepped, basically, I was going to lose a leg. So, what I tried to do essentially is, the way I sort of was assessing it is, I suspected that the patient herself actually probably had like a conversion disorder, essentially, and was using her symptomology to drive the attention from the mother. And so I felt like anything that sort of relied on the patient to speak for herself, but by asking mom to go out of the room or something like that, might cause that to unravel a little bit, which may present problems. So I just kind of went with it, essentially, and I stressed, hey, we don't know what's going on. This is really, really important. We want to make sure we get to the bottom of it. I'm going to clear my schedule. So I had them come back in a week. They showed up on time, almost on time this time. But through that, it gave me more time to delve into the record. And essentially, I was able to find a distant note that basically said, hey, a lot of this stuff happened the very first time, whenever the patient felt that she was under the thumb of her parents. She wanted to be an adult and go to college and make her own decisions, and mom and dad are telling her what to do. And therein enters the dysfunction, right? And so acknowledging that during the repeat appointment, without really addressing her symptomology as much, as far as, okay, you have schizophrenia, you don't, that sort of thing, and suggesting basically therapy, family therapy or individual therapy. Because the way I was looking at it, all of this seems like it's stemming from continued interpersonal conflict in the family, in that it's through those conflicts that she goes to the boyfriend's house and uses substances, or her room and uses substances, and those sort of things. So that seemed to make both of them very happy. In fact, when I suggested that, the patient let out a big sigh of relief and looked at her mom and smiled. And it was kind of interesting to see. I should say now, at the end of the first appointment, the only thing I prescribed for him was Narcan, just to say, hey, pick this up, keep it on the shelf just in case you need it, basically. But I was able to get them to come back, and I think I think they're going to follow up with what I asked them to do. And I think, just to sort of wrap it up, oftentimes I feel like one of the most important things I can do in terms of helping somebody with a substance use disorder is just to prolong my contact with them. And so sometimes that means not even talking about the substances, just talking about whatever they want to talk about, and then they come back and see you next time, and it's through repeat visits that you get to that point. And that's really what I was trying to go for. And I think I was able to do that to some extent. So I appreciate everybody weighing in.
I would like to open up the floor for any additional comments And I did see in the chat about asking about what was being done for her pregnancy follow-up.
That's right. It's exactly where I was going. Was she great case, Dr. Lavin, thanks so much. Do we know how far along she was in her pregnancy, and if she was plugged in yet with prenatal, with OB care?
Yeah, so she was 2 months, and she is plugged in, but it was outside of my system, so I couldn't really see the specifics. But mom was clearly very involved in kind of shepherding her daughter where she needed to be. So that was being taken care of.
How was she feeling about her pregnancy?
A good question. So I did ask her that because, again, I really know nothing about this patient. And, I suspect she was actually overwhelmed and scared. I think what she said was, she was happy about it, and that she wanted to carry the baby to term and so on and so forth. I don't know this is subjective, but I kind of felt like she may have seen becoming pregnant and becoming a mother as sort of validating of her young adulthood in her mother's eyes. And so sort of like allowing that separation, that distinction to be a little bit more black and white, if you will. But it was fairly clear that, I mean, it was unplanned, that really hadn't thought about, okay, well, how does this work? How do we pay for the basics? How do we do X, Y, Z? At this point, you have a young adult who really is relying on her mother for just, I mean, even to answer basic questions, basically. So good question.
Sometimes I weave that into really all the time I'm pregnant women, I weave that into the discussion about treatment for substances. Like, how do you feel about the pregnancy? Do you want to keep the baby? It is true in Texas still that positive urine drug screens, you will get an automatic CPS consult, and it unfortunately really does risk separation. And how do we help you start to demonstrate that you want to get help and change? If you do, is another discussion. And she maybe nobody has ever even given her the option of, you might not want to keep the baby, which is also okay. I don't know. It's starting to help people, especially who are very young, start to think about that and have that discussion, especially since she's early on, where she has the time to sort of think and plan and talk to her boyfriend and all of that stuff.
So I wanted to make one comment. And again, thank you, everybody. So the last question I could see here, I probably missed some, but did I refer to a recovery group or ask her if she wanted to quit using drugs? I did not. And so, in my experience, when there is a very complicated dynamic in the room, and essentially if we step back, I think the patient's unspoken concern is that, hey, my parents aren't treating me like an adult, basically. And the mom's concern is, my daughter's using substances and we think she's schizophrenic and that sort of thing. And sometimes I feel if I would have asked her specifically just more about the drugs, like, hey, do you realize this is a problem, and that sort of thing, it kind of validates what mother is saying, which then drives a wedge. And I've also found, unless somebody's really essentially ready for action, if you jump to that, you're not really going to get the uptake necessarily. So again, my sort of long-term play here is to, let's listen to both sides, but convey to the daughter, hey, I'm taking all this seriously, I'm on your side, and get them to come back, basically. Because I think that it's a complex case and it requires more than, an hour and a half of meeting with them. So good question.
And it's so hard because, pregnancy is such a short window. Really, to sort of be able to do that and sort of establish that rapport and get to a point where we can offer some services. Because I think, Dr. Walker, you brought up the substance use and reporting to CPS, and it's like, yes, we're mandatory reporting state. Those sort of positive results have to get reported. And it's something like 50% of all removals from the home involve substance use in Texas. It's such a short window to try and drive any sort of treatment during that time. That's really, it's hard to walk that tightrope.
It's heartbreaking.
Did you have something to say, Dr. Walker? So thank you so much. This has been a great discussion. And in the interest of time, I will request Dr. Weems to summarize some of the recommendations today.
Yeah, the first summary is, if anybody has learners or other team members who need an introduction to screening and initiating treatment for OUD for pregnant people, these sessions are recorded, and Dr. Sartor's talk will be available on YouTube. That was just really excellent. And thanks so much. In terms of the case discussions, a couple efforts at takeaway points. One is a thoughtful interprofessional approach to allying with the patient. Some things Dr. Lavin shared about being flexible with follow-up, prolonging contact, and really focusing on engagement rather than doing, especially what us providers always want, is like skipping forward to the plan. Instead, sort of backing up, learning from our peer colleagues and saying, how do we ask open-ended questions and figure out what this person wants and how we can help them move in that direction. So really patient-centeredness and working with the team. And then one thing I'll add on at the end that I think was implicit in the case was risk reduction. So harm reduction is always an approach both to engagement and to address the very real risks this young person is facing of unintentionally overdosing on fentanyl. So naloxone at the first visit, the second visit, and anywhere else you can. Thanks so much for a great discussion today, everybody. Everybody have a happy holiday.
Thank you so much.
Thank you. Same to you. I'm sorry.
Thank you all for joining today's Echo. As a reminder to NCME and CNA credits, please complete a post-session survey using the link in the chat. We look forward to seeing you all at our next session on Thursday, January 19. Have a wonderful rest of your day and happy holidays, everyone. Stay safe, stay healthy. Bye-bye.